Hey, what's up, and welcome to the next live case demonstration in Power Up Endo's 90-day Super GP training program. This case is going to be building on the last cases that you've observed and followed along with, and we're building in our complexity all the way up to, like I mentioned, that big bad upper molar with an MB2. All right, so let's get right into this case. So this is a patient who came to my practice. She was in her mid-20s. She had a lot of carious lesions, and she was a new patient to her general dentist, specifically for her tooth pain, but just also to establish herself in the general dentist's practice. So the patient has a lot of carious lesions, but she's very specific as to her pain, and she's pointing right to tooth number 4. All right. She suffers from pain to cold that lingers, and it's been bothering her for about a week and getting worse and worse and worse. So you can see very clearly on the radiographs that she has caries on multiple teeth in this quadrant, but tooth number 4 has the largest carious lesion going right into the pulp. Okay. When we do our clinical testing on this patient, we discover that she has lingering pain to cold as well as pain to percussion. So our diagnosis is symptomatic irreversible pulpitis with asymptomatic apical periodontitis. Okay? And also, it's important to note that you can appreciate on the bite wing radiograph here that there are 2 canals present inside the tooth, okay? And that's why it's so important to take both a bite wing and a periapical radiograph, okay? Because there might be information on one of the 2 that's going to help you in planning the procedure, and you want to gather as much information before you open up the case as possible. All right, and we can see on the periapical film, okay, in just a second here, that you can't really appreciate multiple canals nearly as apparently as we did on the bite wing radiograph, okay? So this is a great case for a general dentist to handle in their practice, and there's really no reason that once you've gained the confidence and you have the desire to learn and to apply the skills that I'm teaching you, for you to be very successful with cases just like this, okay? Now, this case was hand-selected for a few reasons. Number one, because it's a case that you see probably very, very frequently in your practices, all right? But also because it exemplifies and it demos for you the situation where you have a very large carious lesion that you're having to manage before you actually start the endodontic portion of the procedure. And it's also a great case to utilize the split dam technique for rubber dam isolation. All right. So with the split dam technique, you're isolating a broader area, and it's actually a 3-tooth isolation where you're going to punch 2 holes that are overlapping in the rubber dam, and you're going to clamp the tooth distal to the one you're working on. So in this case, even though we're working on a premolar, okay, we're going to use a molar clamp that's going to sit on tooth number 3, and then we're going to swoop over the rubber dam, floss it between teeth numbers 5 and 6, and then we'll be utilizing the opal dam barrier material to get a airtight rubber dam isolation, because you will not have airtight rubber dam isolation with a split dam because you have so much exposed gingival tissue, and we don't want that gingival tissue that has bacteria to get into the root canal space that we're working so hard to get nice and clean. Okay, so this is a great case to demo that for you. So we've already anesthetized our patient, and we're going to go ahead and proceed. You can see that there's a large bite block present. I always place the bite block and the apex locator clip. So here we have our rubber dam isolation, just like I mentioned, and we're just flossing down that split dam isolation to have a 3-tooth airtight rubber dam isolation. Okay, and so again, this is so great to utilize the split dam when you have that large carious lesion, so that your burr doesn't get snagged up in the rubber dam. That's a very startling event to the patient, and you want to avoid that at all costs. Also, when you have a when you have a situation like this, you may want to restore the case right away once the root canal treatment is complete. And so it's nice to be able to have room to place your matrix for your restoration. So we've lowered the occlusion quite a bit on the buccal and the palatal cusps, and now we're working on our caries control. Now, like I mentioned before, lowering the occlusion is very important because it's going to give you stable reference points for your working lengths, and it's also going to reduce some of that post-operative pain that your patient may experience when they are recovering from their root canal procedure, right? So I don't need to go into detail about how to do caries control. So I'll take this opportunity to just discuss the importance of not leaving any caries behind when you get into your endo, right? So all caries has to be removed, all right, before you initiate your endodontic treatment. You don't want any bacteria from the carious lesion getting into the root canal space, number one. And number two, you want to be on sound tooth structure so you can orient yourself best, especially with premolar teeth. So premolar teeth have a pretty narrow cervical area or neck of the tooth, and when you're doing your access preparation, if you're not careful, it's very easy to lose your angulation and potentially, perforate out the sides. Even though, premolar teeth are considered to be a little easier, they're not so easy sometimes, and the access prep can be tricky. Now, you're going to likely get some bleeding when you have a deep carious lesion like this from the gingival tissues. So I like to use the System B with the fine medium 08 tip, that heat source, to cauterize the gingival tissues to get a nice dry area. All right, it's like a crude gingivectomy, if you will. If you have a laser and you want to do that, go right ahead. I just keep that on hand, and I'm going to use it anyway later in the procedure, so it's nice to have. And I just pass that along the area where it's bleeding and just cauterize the gingival tissues and remove some of that excess inflamed gingival tissues, right? The patient will likely smell some burning of the gingival tissues. They won't feel anything because they're obviously anesthetized, but that smell can be a little startling to a patient. So I like to have the assistant hold the high-speed suction close by to try to evacuate as much of those fumes as possible. And here I'm just using my number 4 round burr to actually just remove all that caries interproximally. All right, so we're still working on our caries control. It's important to take your time, okay? If caries is in the way of where you're working, number one, it's easy to lose angulation because you don't have really obvious anatomical landmarks, and number two, you can't see any potential cracks that might be present. All right, so now we're getting into our access preparation. So I'm using a number 4 high-speed surgical length round burr here just to gain entry into the pulp space, and I can get right in there. Now, we know that there's 2 canals present already in this case, okay? But if we didn't, it's going to be important that when we find that first canal, we appreciate that it's not centered in the tooth. So when you use your Endo Explorer like this and you're getting into the canals, if you're into a single canal that's centered along the central fossa of the tooth, okay, it's a 1 canal case. If the canal that you initially find is off center, either buccally or lingually, that's another way you're going to be able to determine clinically that there's more than 1 canal. So now we're introducing our ProTaper Gold SX orifice opener, and we're just passing it into the buccal canal and then eventually into the palatal canal. And remember, you want to introduce the orifice opener and then do a lot of brushing motions away from the furcation. So in the buccal canal, you're going to brush buccally, and in the palatal canal, you're going to brush palatally. Okay, you're not trying to, push this file or any other rotary file for that matter, but you're just trying to make some space coronally and trying to orient yourself inside the case so you can begin the process of instrumentation. So a little sodium hypochlorite here. Just be very careful because you don't have that airtight rubber dam isolation yet because you don't have the opal dam green material on there to not let any sodium hypochlorite get into the patient's mouth. All right. So that looks, we get a nice sense of what the case looks like now. And now we're just modifying our access prep and making some fine tuning using the Endo Z burr. Like I mentioned, the Endo Z is a non-end cutting burr, and it's used to just round off the internal aspect and kind of give you that final shape of the access preparation that you're trying to accomplish. Okay, so just a back and forth action to give you some nice smooth angles inside that axis preparation. But you can see very clearly there we have two canals present, the buccal and the palatal canal. Okay, so it looks starting to look nice and clean. And I'm just taking my time here, making sure that all the caries is removed before I get into the meat and potatoes of the endodontic procedure. So take your time. Sometimes this is one of the more time-consuming aspects, just to make sure you're on sound, solid tooth structure, and that you're not leaving any caries behind. And sometimes there's some pulp tissue, just beyond that hasn't been fully unroofed. And so you want to just kind of take your time and make sure that coronal area is nice and dry and you have good control of the case, in terms of the unroofing of all the pulp horns. But you can see it's starting to look nice and clean in there, nice and neat, and it's on its way. So coming up now, we're going to start with the application of the Opal Dam Green material by Ultradent. And you can see that there, and it's just going to be squirted around any area where you can see soft tissue or gingival tissue. That's going to be a potential ingress point for your sodium hypochlorite and a possible point of contamination from the saliva wanting to seep its way up. Okay, we want a really, really airtight seal. We also don't want any bleeding to get into the area, right? So we want it to be airtight. So we're applying that circumferentially, and then we're going to go ahead and light cure that for 20 seconds. And so we got a nice clean field there. All right, so now we're proceeding to our working length determination and our glide path preparation. So we got our size 10 C file in there that's being introduced into the buccal canal, and we're just utilizing a watch winding motion. It was initially described back in the late 80s as the balanced force technique, but it's essentially just a watch winding motion of the hand files to progress to the apex. And we're just kind of passing that 10 file down. If the 10 file is not progressing to the apex, then by all means go down to an 8 file to make sure you get to the apex. But I generally want to take my working length with my size 10 files. And remember, sizes 8 and 10, I'm recommending you utilize C files, and then sizes 15 and above, you can go ahead and use your traditional K files. But again, C files are nice because they're a little stiffer and they're good at breaking through calcifications, which is what you need early in the procedure to get your working length. And now we're going ahead and moving on to the palatal canal and doing that same thing with the 10 file. Okay, getting to length and obtaining a measurement. Both the buccal and the palatal canals are found in this case to be 18.5 millimeters. Okay, and you want to just take your time and make sure that you have a nice stable reading on your apex locator right to that point that I mentioned between the number 1 and where it says apex. Okay, that's going to be a great endpoint for you. So take your time. Also, I recommend for cases with multiple canals to be very, very clear and consistent as to what your reference points are. And so for the buccal canal, I utilize the buccal cusp as the reference point. And for the palatal canal, I utilize the palatal cusp tip as the reference point. Okay? So I'm just recording those measurements. And now I'm going to be going up to a size 15K file in each of the canals to 18.5 millimeters, our working length. And that goes pretty smooth in a case like this. And then we're going to introduce another 15 file into the palatal canal so that we can take our working length radiograph. Okay, and you can appreciate the little bends on those hand files. Like I said, every hand file that gets introduced into the tooth has a slight curvature to it. You just lean against your mirror and create that nice soft curve. Nothing sharp, just a nice soft curve. All right, so you can see our 215 files and our working length radiograph. That looks good, right to the apex, just like we like. So we're happy, and in my opinion, getting to this point is, more than half the battle, and we're all downhill from here. So now we're introducing our size 1504 Vortex Blue rotary file. First in the buckle, to length, remove, wipe the file, put some EDTA or some RC prep on the file, and then go and do the same thing for the palatal, okay? So that's the routine. Rotary to length, remove, wipe, RC prep, rotary to length in the other canal, and then irrigation between every increase in file size, all right, with our half-strength sodium hypochlorite. So now we are introducing our size 2004 Vortex Blue rotary file, again first in the buckle, all the way to 18.5, wipe, RC prep, and then into the palatal. It's important to use your 2x2 to wipe the flutes of the file to remove any of that dentinal debris, all right? The reason that that's so important is because if the flutes are filled with dentinal debris, okay, they cannot cut. So it's very important. It's like trying to have a spoon that's full of sugar, let's say, and then going back into the sugar bag and trying to remove more sugar. The spoon is already full. You have to remove all that sugar from the spoon before you can grab more sugar, right? So you got to have a empty flute in order to do the proper cutting. And now we're proceeding to our size 25 Vortex Blue 04 taper rotary, first in the buckle, and then wipe, RC prep, and then into the palatal all the way to length, both at 18.5 millimeters. Okay, we are moving right along. Again, sodium hypochlorite between each file that you pass. And we're working our way up the ladder. This gets a little bit repetitive here, but that's nice because then your assistant and you can kind of like do the dance and get through all the steps in a very predictable manner. That's the whole idea. All right, now we are moving right along to our size 3004 Vortex Blue rotary file. In the buckle, wipe, RC prep, and then into the palatal. And we're gonna go up one more size in this case. Okay, generally speaking, especially for a vital case and for most canals, a size 35 is a great endpoint. That's not a hard and fast rule by any stretch, but that's generally the size that I typically end with in a lot of my canals that I'm instrumenting. So that's a size that's reasonable in terms of making sure that you're fully debriding. And now, like I mentioned, this is our size 35 Vortex Blue 04 taper rotary in the buckle, and then into the palatal. Okay, so the instrumentation phase doesn't really need to take this long once you kind of learn the dance with your assistant. Okay, and you guys are in the groove. Okay, but that's our final shape. You can feel the resistance on the file in the apical area, and that's how you know you're fully debrided. You can finish at a smaller file, you can finish at a larger file, but you just don't want to push any file that's too fat all the way to length. So now we're getting into our disinfection stage, all right? So lots of sodium hypochlorite here in the two canals, and then we're going to aspirate out our sodium hypochlorite in both of the canals. That's what we're doing first in the palatal, and then in the buccal canal. And then we're gonna proceed with our 17% EDTA rinse, okay? So you only need 3 milliliters of this or so in the syringe. It's not as critical that you soak it for a full 60 seconds in a vital case like this, okay? So you just wanna make sure that you pass some EDTA through, and then back to our final rinse of half-strength sodium hypochlorite, okay? So remember, hypo, 17% EDTA, and then more hypo at the end. All right, and that looks good, nice and clean. And now we're gonna proceed into our obturation phase of the treatment, and we're gonna be introducing our F2 paper points here in just a second. And the beauty of aspirating out the fluid is that we can get away with a single paper point typically per canal. All right, so it makes it very efficient on the materials and material side, and also efficient in terms of time, not having to use 5, 6, 7 paper points per canal, right? And now we're introducing our Premolar BC sealer into each of the 2 canals, injected directly in. Just make sure that it's a passive fit so you're not squirting any sealer through the apex. And then removing the sealer tip and dunking the gutta percha cone that's been crimped at the appropriate length into that tip, and then introducing that into the 2 canals. First into the buccal canal, all the way down to the crimp, and then to the palatal. Now, it's very important. I typically will obturate with gutta percha cones that are one size below whatever I instrumented to. Reason being that the Premolar BC sealer is quite thick, and oftentimes a matching cone will not go all the way to length. So I typically will obturate one size down. There's our cone fit radiograph, right to where we want, and that looks good. So now we're going to go ahead and sear off the gutta percha cones right at the orifice and get into our compaction. Okay, that System B tip there is used. You don't have to go too deep into the canals. You just want to have enough to work with and enough to compact at that orifice level. And we're compacting with our Buchanan hand plugger size 1, that's the red, and we're using the larger size of that red plugger. And that's the plugger that I use for 90% of my cases. Okay, and just kind of packing that down. Sometimes I go in with the System B tip in order to clean up the excess, and I'm actually using that same System B tip to leave the post space in the palatal canal. So I like to essentially activate the heat, insert to the appropriate length for your post space, let it cool for 3 seconds, and then activate the heat and pull out in order to remove the gutta percha that's in that post space that you're trying to remove. Alternatively, you can simply use a Gates Glidden. I use a size 4 Gates for most cases to prepare that post space. That's going to give you a little bit more predictability in terms of the chance of you pulling out your gutta percha cone. And if that makes you feel more comfortable, by all means, go ahead and do that. Okay? You probably are used to using that as opposed to the System B tip. But if you want to use the System B, that's nice because you don't remove any dentin at that point. All right? But I do both. I use the Gates Glidden oftentimes in order to just clean out that post space and make sure that it's a nice, neat area. And you'll have a lot of excess gutta percha, obviously, from your post space preparation that you'll need to manage, but it's not too hard, especially in a multi-canal case, because you have room to work at the level of the canal orifice. All right, so you can see that's kind of taking shape, and I'm just kind of making my fine-tuning and final adjustments to deliver a nice, clean end product to my referring dentist. But if you're going to be restoring your cases right away, do yourself a favor, give yourself a nice, clean foundation to work with, and don't cut any corners. I don't recommend cutting any corners. Just doing everything properly in a super time-efficient manner. All right, and sometimes the cleanup job, takes a fair amount of time. That's okay. Do it right the first time. But that's starting to look obviously like a nice finished product. But sometimes you have that gutta percha, along the walls, and it can be a little bit tricky or annoying to get it all out. You can use your Buchanan pluggers, you can use an Endo Explorer, whatever it takes to kind of snake in there and make sure there's no gutta percha internally on the walls. And then for drying the post space, I will always use a paper point. So just kind of jostle a paper point in there just to get a nice dry post space. And you can see that there to length. And I just found a little gutta percha there on the buckle that I want to just remove. Yeah. And then we're going to go ahead and measure our post space here in just a moment to make sure it's at the length that's appropriate. and you can see that that goes all the way down. The post space was measured and found to be 11 millimeters in this case. And so I'm just seating that to 11 millimeters and then measuring it just to ensure it's the appropriate depth for the referring dentist. And now I'm just kind of making sure the gutta percha is flat at the depth of the post space and at the buccal canal orifice as well. All right, but that looks good. So now we're going ahead and dealing with our temporary restoration by placing our green sterile sponge. But like I mentioned, if you'd like, go ahead and perform your definitive restoration here by first removing your opal dam, and then either placing your Tafelmeyer matrix or your composite ring and restoring. You can restore just with the rubber dam on because you have this split dam isolation. You have the room to work. You may not be able to fine tune your inclusion, obviously, with the rubber dam on, but you can do the majority of your restoration. And I use the spoon excavator to remove that opal dam green just by getting under there and kind of flaking it right off. Okay. Be careful to not flip off the rubber dam clamp. That can happen. And there's a little unsupported enamel there that I'm just cleaning up, but you get the idea. Sometimes when you remove the opal dam green, you're going to have a little bit of bleeding from the gingival tissues. That's still inflamed, obviously. So in this case, I went ahead and used the System B again just to get that nice dry area to work with, so that my temporary restoration is being placed into a nice dry field. So I'm placing my Fuji 9 glass ionomer here on top of the sterile sponge, and I wanted a nice hard temporary restoration, and so that's being put into place. And then I'm using my Glick in order to give that provisional restoration some shape. All right, and that looks good. So we're going to take off our rubber dam here in just a moment and take our post-op radiograph. And you can see, that's a decent shape with our Fuji. And there's our post-op radiograph. You can see that the buccal canal is filled and the palatal canal as well, with the post space left in the palatal canal. With our temporary restoration, the patient's going to do great. Obviously, she has other carious lesions that's going to be addressed by the general dentist. Potentially more endodontic treatment that needs to happen, but this patient is going to be out of pain as soon as the anesthesia wears off and some minor soreness wears off. Okay, so I hope you can appreciate how powerful this is. This procedure, once you get good at it and kind of get into a routine, oftentimes will take you less than a half an hour. I performed this procedure, in about 22 minutes or so, and if you placed your definitive restoration in the tooth now, you will have had, maybe 40 minutes of chair time and a very, very profitable procedure, and a patient who had all this done in a single visit as opposed to having to come back to the office multiple times or, going across town to another provider. And it is just a great service you can provide for your patient. The patient is going to rave about how fantastic you are, and you will have been very productive with your chair time. All right, so I hope you appreciated this live case demonstration and learned a lot from this. It's just another stepping stone to get you on your way to being a super GP. I will see you in the next lesson.